Okay, we are recording and ready to go. Anyone else in your office that may have missed this, isn't able to join, we will send out this recording right after the meeting, hopefully by the end of today, so that everyone is able to review this. So thanks for joining. We're going to talk briefly about HCC coding, what it is, why we're talking to you about it, and how it impacts the ACO. So many of you have probably heard about HCC coding through your Medicare Advantage plans. They rely really heavily on these HCC and weighted codes to figure out how much money to assign to each patient throughout the year, what it's going to cost to maintain and manage these patients. Of course, Medicare, regular Medicare and ACOs are definitely different from the Medicare Advantage plans, but some of this stuff is going to overlap. So hopefully you've heard a little bit about this. So just a reminder that this is all about appropriate and effective coding. We want to capture the true status of your patients, what's actually going on with them. This is not upcoding. This is not putting down diagnoses that aren't correct, aren't current, aren't appropriate. We want just a good total view of the status of your patients so that we can really know truly what's going on with them, what all their diagnoses are, and understand truly how sick these patients are. So, it's pretty simple. More accurate coding leads to more accurate and comprehensive care plans. Because we have better care plans, they lead to better preventive medicine and quality of care. They indirectly influence performance payments for you in the ACO, and they indirectly influence performance measurements within the ACO. So there's lots of things that go into appropriate coding that all get rolled in here, not necessarily right at the time of the visit with the patient, but further down the road when we look at our performance payments, ACO payments, and GPRO and performance measures. So just quickly to talk about, you've probably heard the term or seen the term RAF. So risk adjustment factor is showing the score of the member, really adding up the score of all these members' diagnoses. This identifies the member's health status and really shows what's truly going on with the patient. A lower RAF score for a patient could indicate that patient is healthier, or a lower RAF score for a population like an ACO could indicate that this is a healthier population. A general Medicare patient is about a 1.0, maybe a little bit over RAF score. Anything above 1.0 would be a sicker patient, a more complex patient, and less than a 1.0 would be a less sick patient. So if a patient has a lower risk score, again, that could indicate that they're slightly healthier, or it could indicate that there's not enough documentation in the chart. Maybe the provider is writing notes in the notes section, but these are not translating into actual diagnosis for the patients. Maybe we have a lack of complete and accurate ICD-10 coding. Some practices might still be stuck back in that ICD-9 mindset, where there weren't as many diagnoses, they weren't as complex diagnosis, and so if we're only coding things that are very unspecified or not very complex, that could lead to a lower risk score. And then patients that have not been seen can also lead to a lower RAF score. These scores start over at 0 every January. So any chronic condition, anything that stays with the patient year over year is going to have to be coded year over year. If you only saw the patient once and you only coded the few acute things that were going on with that patient, then you didn't get a chance to give Medicare the full picture of how sick this patient was. the rest of their chronic conditions did not get adequately coded and billed and documented. And then the patient never came back, and we never had the opportunity to do this again. So all of these could lead to lower RAF scores, lower risk scores for your patients, and in essence, you're showing Medicare that this patient is less sick than they actually are. There's a direct correlation between this stuff and our shared savings within an ACO. I'm going to let David Klabonis tell us a little bit about this, because we don't want you guys to rely too heavily on this. This is just one part of the whole puzzle. So David, you're unmuted now. Do you want to give us a little info about what we're looking at here on this slide? Well, I thought David was unmuted. Let's see. All right, David, can you say something? Let's see if we can hear you now. Little technical difficulties, that's all right. So let me just briefly walk you guys through this. So this is just a reminder that we are talking about this stuff, and this is important, but it's only a drop in the bucket, okay? We have a whole lot of lives here in Doctors ACO. We have a 75% savings rate now in Doctors ACO now that we are in the risk track. We have a much larger opportunity to improve our cost savings and our benchmark by doing the things that we have always done within an ACO. Things like ER prevention, good quality reporting, annual wellness visits. This is stuff that we want to make sure that we continue to do. The maximum we can change our benchmark within Doctors ACO with updates to MRA and HCC codes is 3%. And honestly, because it's 75% savings rate, it's only 2.25% that we can change this. So there is a maximum benefit that we can get from working these HCC codes and improving our MRA scoring. That's not to say it's not important. It definitely is, but we don't want you guys to lose sight of the big picture here. When we focus on all the other things that we've always done as an ACO, the ER diversion, the good quality wellness visits, the TCM, we can potentially have cost savings of up to 20% of our benchmark within the ACO. So that translates to millions of dollars in improvements, $31 million if you're looking at our specific numbers, versus just a $3.5 million adjustment that we could make if we coded every single patient perfectly. So this is just a little disclaimer that we don't want you guys to hire additional staff to exclusively work on MRA coding. Don't drop your other initiatives to work on MRA coding. There are lots of other things that are important in an ACO. This is just one of them. So don't get too hung up on this, but let's pay attention to it as we go into the end of the year here. So just a little review of your RAF score, your risk adjustment factor scores. Each patient gets a score that includes their demographic information, like their age and their sex, their Medicaid status if they're dual enrolled, and if they were eligible for Medicare due to disability, that gets counted in there as well. And then all of their chronic conditions and a number of disease interactions as well. So Medicare recognizes that certain diseases interact with each other. Say, for example, diabetes and CHF might interact, or chronic kidney disease. So if we are diagnosing these multiple chronic conditions, Medicare automatically jumps in and gives you an additional boost in the RAF score because of disease interaction. There'll be a little bit more about that later too. So just as an example here, this is the same patient. The left and the right are coding visits for the same 66-year-old male on Medicare. If we're looking at the left side, this is almost lazy coding, honestly. We have coded that he has uncomplicated diabetes. That's the first line. We have coded that he has some neuropathy somewhere, not very specified. He's got some depression. Again, we don't know if it's chronic or single episode. We don't know if it's major depression or mild depression or not. He's obese. He's had a great toe amputation. When we add all these up, he gets a total HCC score of 1.19. Okay, so a little bit sicker than the average Medicare patient. But and then Medicare says, okay, well, based on those diagnoses and that risk score, that RAF score, we suspect it'll cost about $12,000 to manage this patient for the year. Okay, so all right, based on what you've told us, $12,000 for this patient. Now, if we look over on the other side, on the right side, this is the same 66-year-old male patient, but this time we've gotten a little bit more, we've gotten into the nitty-gritty of what's going on with this patient. We've coded this time that he has diabetic neuropathy. That neuropathy actually came from his diabetes. We've linked those two together. We can still code that he's got just general neuropathy, but we should code the complex diabetes, not that he is uncomplicated, but that he has neuropathy due to his diabetes. He could also have some ophthalmological disorders or some nephropathy that goes along with his diabetes. All of those should be coded. You see that this diabetic neuropathy diagnosis has a risk factor of 0.368 versus the 0.118 for the uncomplicated diabetes, so a much more weighted score. For his depression diagnosis, we actually quantified it. We said that it's mild depression, and if we look at this ICD-10 code, we can see, if we looked that up, we would see that it was single episode as well. So it was just a single episode of depression, and it was mild. Something we want to check back in on, but maybe something that he's not going to be on medication for. It helps us get a better idea of what's really going on with that patient versus just the unspecified major depression. We've moved down to obesity, and this time we realized that his BMI was over 40, so we were able to code him morbidly obese. You were also able to code morbid obesity for a patient with a BMI over 35 if there are other underlying conditions that can be attributed to this weight. So, and you'll see that in some of the resources that we give you. We kept that great toe amputation on there. That's a pretty big weighted code, set 0.779. Any amputations are heavily weighted, and these are things that typically will get missed year over year because there's something that they don't go back. Maybe this guy has had a great toe amputation for years. We don't really even think about it anymore, but we do have to make sure we code it every year to tell Medicare that that toe did not grow back. And then this time we remembered to code his congestive heart failure. Perhaps it's something that is well maintained. We ask him the basic questions, any trouble breathing, any unexpected weight gain, things like that. He says no every time. And we just forgot to code the congestive heart failure last time because it wasn't something that we actively look at every time he's there. We do need to monitor and treat that condition at least once a year. And of course, if you're giving medications or anything, you're going to monitor and treat that condition. But because we added it onto his visit this time, then Medicare came in and gave us this disease interaction factor of the 0.154 for the interaction between his two chronic diseases, his diabetes and his congestive heart failure. So now this guy has a 2.61 total risk score, more than twice what he was before. Same patient, basically same diagnosis. We just coded to the highest level of specificity, highest complexity for these diagnoses. And now Medicare says, hey, you're right, this guy, it's going to be closer to $26,000 this year to maintain his health and manage his patients because you've told us all of these chronic diagnoses. There's a big difference between that. So we want to make sure that we are accurately coding our patients so that we are accurately and appropriately telling Medicare what it's going to cost to see these patients, to maintain the health of these patients through the year. Think about it. If we coded all of our patients like this guy on the left, and we coded them all just basic, uncomplicated, unspecified diagnosis, and we multiplied this number per patient by the number of patients in the ACO, perhaps it's $100 million to manage our ACO patients this year. But if we had truly and accurately coded for all of our patients and gave them appropriate risk scores, we may tell Medicare that, you know what, we told you previously that it was going to cost $100 million to manage our patients, but it's actually closer to $110 million based on accurate coding. That's a $10 million deficit that we would have to really make up in what we're doing on our day-to-day to reach shared savings. Every little thing that we do helps and helps bring down costs, but we are already starting at a deficit if we're not coding appropriately. So this really helps not only give a better picture of our patients to every provider that sees them, it makes your life a little easier because you know what's going on with that patient. By quickly looking at their diagnosis, you've got a good, complete picture, but it also makes it easier. It raises our benchmark and makes it a little easier to save as an ACO. So really indirectly over time, this appropriate coding will contribute to your performance and your incentives payments. That's to say that it gets easier to save. It gets easier for us to make shared savings over time if we make these small little tweaks. So just a couple things here. Impact of documentation. Our risk adjustment data is obtained from the diagnosis codes reported from claims in healthcare settings like inpatient, outpatient, and the physician's office. So it's not every place that the patient goes. It's not necessarily the labs or the SNFs or the home health cares. It's the physician's office and the hospital. So you guys play a big role in this. We want to report all diagnosis codes that you are currently treating or managing to the highest level of specificity known during each patient encounter. So we're not doing anything higher than what is known at that visit, but we want to show very specifically how sick these patients are and really what's going on with their conditions. You've heard the term HCC Codes. It's an acronym for hierarchical condition categories, and I don't say that often because I have a hard time saying hierarchical. So HCC. These are the categories that these diagnoses are broken down into. And then just a reminder that it resets each calendar year. So it is really important that we document and code all of these diagnoses and comorbidities that are evaluated by you every calendar year. The wellness visits become such an important visit for this because you know you're going to see your patients every year for that at the very least. That's a great time to make sure that you are coding everything at that time. We have some help in BlueSky that really helps out with this, and you're going to see a couple of slides on that stuff here in just a second. A couple of more documentation guidelines. Make sure you can code all documented conditions that coexist at the time of the encounter or visit and require or affect patient care, treatment, or management. So we've had some questions about, well, do we code things like cancer if they're no longer there, if they are in remission and they're not being treated for that anymore, or conditions that aren't that were there in the past and are not there anymore. You would not code these conditions that were previously treated but no longer exist. Okay, acute things, they will fall off. You can use history codes, history of breast cancer, history of stroke, if they, or family history, if they have an impact on the current care or they influence your treatment for this visit or encounter. And again, you have to be treating and managing that condition in order to code it. A couple of commonly overlooked diagnoses here. Organ transplants get overlooked a lot. Artificial openings, stomas, feeding tubes, things like that. That has a pretty high weight. Amputations, of course, we've mentioned that in the past. Let's make sure that we're getting really specific. Is it the left leg or the right leg? Is it below the knee or above the knee? Be real specific. Obesity, again, that morbid obesity is one that carries a lot of weight. So if they have a BMI over 40 or a BMI over 35 with other comorbidities that are caused by the obesity, then let's make sure that we're diagnosing that. Dialysis is missed a lot of times, paraplegia, quadriplegia, HIV status, and an old MI. Again, if this is, you would only use this code for the older healed MI if it is, let's go back to the wording from this previous slide, if it has an impact on current care or influences treatment. This is just a reminder that it does have to, in order to bill and code for these diagnoses, it has to come from a face-to-face visit. So don't think that you can just go back and look through all of your documentation and start adding all of these codes. You do actually have to see the patient face-to-face. The condition must appear in both the assessment and the plan when you see this patient. So you can't just say that they have COPD and then diagnose or put that on your codes. You have to say that they have COPD and that it's stable with their current medication and mention that medication. Make sure that you have an assessment of the disease and a plan. Nice, easy little acronym to help you remember, MEET. So if you have monitored, evaluated, addressed, and treated the diagnosis or the condition, then you can bill and code for that. Some things you might monitor, maybe, but you don't address and treat. Or maybe you just address it and you're not evaluating and treating it because that depression is being treated and monitored and evaluated by their psychiatrist. So make sure that you are actually meeting the chronic condition before you bill for it. Don't want anybody to get in trouble here. And one final reminder, more accurate coding leads to more accurate and comprehensive care plans. Better care plans lead to better preventive medicine and quality of care. They indirectly influence your performance payments, and they indirectly influence performance measurement, our quality. This is important stuff. Again, not the end-all be-all. We don't want you to drop everything that you're doing just to work on HCC codes, but this is important stuff. So BlueSky, you all have access to BlueSky. I know quite a few of our practices log into it regularly. BlueSky, hold on just a minute here for me. BlueSky has a whole menu that shows dropped HCCs for the calendar year. So for example, anything that was coded in 2018 that was not coded in 2019 will show up in these reports. So I've pulled the top 10 for Doctors ACO. These are the HCC categories that had the most percentage of dropped codes. Number one up here. Now we only had 10 diagnoses in this, but 9 of them were dropped. This was traumatic amputations and complications. This might not be something that often gets coded in the PCP office. But let's not forget those amputations. Make sure that we're coding those every year. Fractures without spinal cord injury, vertebral fractures without spinal cord injury. Coma, brain compression, we had 43 diagnoses last year in 2018. 36 of those were dropped. Intestinal obstruction or perfusion. Again, if these were acute things, they were fixed and we've moved on from it, then we wouldn't recode again this year. But things like protein calorie malnutrition, that happens a lot, with our older Medicare patients. This is a pretty heavily weighted code. If they are continuously underweight and you are able, you diagnose them with malnutrition, let's make sure that we're coding that. Look how many times, 360 times that was diagnosed, and 292 of them were dropped. 79% of those were dropped. Chronic skin ulcers, except pressure ulcers. And then down here, number 10 is pressure ulcers. So those, those come and go, but for long-term pressure ulcers and other skin ulcers, let's make sure we're diagnosing those and keeping those on every year. So again, these are just the top dropped ones in Doctor's ACO this year. And you have in your, sorry, let me advance my slide here. This is an example. Now, this is not actual patient information. This is all scrambled for you. But this is an example of what you can see in BlueSky. You'll have all the patient's information, and then you'll have the dropped codes from last year. You'll have who diagnosed those codes. Here are the last diagnosis in the last column, and the date that that diagnosis was the last date of service for that diagnosis. So you're able to easily see for all of your patients what weighted codes have not been diagnosed yet this year. So we can look and see if any of these are still appropriate. And then if we are needing, monitoring, evaluating, assessing, and treating these conditions, let's make sure we're coding for them. So again, these reports are available in BlueSky, and your consultants are going to be bringing these around to you. A lot of you already have some of these dropped HCC codes lists, and your consultants will be bringing them to you if you don't have them yet. If you haven't seen them yet, give us a call. You've got Amy and Brian and Neil. Call us up, and we'll make sure to get this to you as quickly as possible, or we'd love to walk you through BlueSky and how to pull this yourselves. So let's see how many of these dropped codes we can pick up through the end of the year. Annual wellness visits are a great time. TCMs are a great time to make sure that we've updated things. And then, of course, seeing your chronically ill patients before the end of the year. We're supposed to be seeing them minimum of 4 times per year, and here we are in October. So we could probably get every single patient with a dropped code in before the end of the year if we really try hard. So this is a great opportunity to pick up a few dropped codes here, boost our benchmark a little bit, and give you an extra opportunity to see this patient and make sure that they are set to get them through the flu season, and hopefully stay out of the hospital as we go into this fourth quarter and into early next year. All right, so before we take questions, we do have David back on the line with us. David, I'm going to unmute you, and I'm going to jump back to your previous slide. I gave my best overview of it. David, you're going to have to unmute yourself. Let's go back.
Hello.
Hey, David. I'm going to let you always are really good at talking about this stuff. I know I didn't do your slide justice, so I'm going to let you go over this benefit to the ACO slide for us one more time, if you wouldn't mind.
No, that's perfect. So in Medicare Advantage, there is a big focus on MRA. In ACO, the government has not done the rules the same way as Medicare Advantage, and they only have a limited financial benefit for MRA. So the key thing is that use the detailed coding to improve the complexity to improve the specificity of your assessment, and then use that to have a more detailed care plan. And ultimately, if you can stratify your patients into the ones that are more high risk, more complex, and you can see those patients more often, and then maybe stratify the patients that are less high risk and see them less often. The key part of this slide is you can make an extra $31 million a year from cost savings, but you can only make $3.5 million a year in MRA. So if you look at the first line, it says number of lives, benchmark, savings rate, MRA, max benefits 2.25%, total to ACO 3.5 million. Second line, cost savings. If you look at the last column, 31 million. So please don't stop what you're doing and work on MRA only. Just use the specificity of the coding and some of these little tactics here to make sure you're able to do a fair job at MRA, but also to maximize cost savings. And I think the slide's self-explanatory. Was there anything on here that jumped out to you?
No, I don't think so. You just have such an elegant way with the numbers and the percentages that I don't always have. So thank you for jumping in on this. We are at the point now where we would like to take some questions. And I think the easiest way to do this is through the chat function in your GoToMeeting. I'm going to monitor this chat function, field any questions that you have. If you want to type that into the chat function, if it's easier for you to text me, you may do that as well. But we'll give just a couple of minutes here to take any questions or comments. A reminder again that we sent out the MRA Bazooka. We actually Neil had a great suggestion. If you have a question, if you just type question into the box, I will unmute you and you can ask your question to the whole audience. So if you type question into the chat box, then I will unmute you and you can ask any questions you have. But again, just before this webinar, about 11:15, I sent out an email to everyone in the ACO with a good MRA coding resource attached to it. Now, this is called the MRA Bazooka, and those of you that have been with the ACO for a while remember this from a few years back. It was the two laminated pages together with a ring that had all of the diagnosis, weighted diagnosis that you may use in the primary care setting. That has been updated thanks to our good friends with Palm Beach ACO and help from others. And so that is in your inbox. If you have not gotten that email from me and need me to resend you that MRA Bazooka, if you'll send me a text or type into the chat function that you, whatever your email is, I will make sure that you get that sent. But go back and check that. That's a really good resource, and we'll work to get those out to all the practices too. We do have a question on where to pull the CPTs from BlueSky. So I'm going to say that this is probably the dropped, the dropped HCC codes in BlueSky. So when you log into BlueSky, over on your left-hand menu, there is a menu called HCC Insights. Pretty easy, HCC Insights. And when you click on that, it's going to take you to your list of patients for your practice that have dropped HCC codes between last year and this year. They are sorted by the most dropped codes down to the least dropped codes. And you'll see that there is a column for deceased. Probably the first 10, 20, maybe 30 patients on there will be deceased. And of course, we expect them to not have codes this year because they are not with us this year. So I would suggest exporting that to Excel and filtering that so you're taking out everybody that is deceased. Again, your consultants are going to be bringing these lists to you. But for those of you that are BlueSky savvy and are using that, it's the HCC Insights report. over on the left-hand menu. And if you click on the patient when you pull that up, it goes into detail about every weighted code that was dropped on that patient.
Amy, what's the timeline to roll this out to the offices individually?
Yeah, so we've already started rolling this out to many of our offices. Most everyone down in Columbus got this last week. We've had a handful of our Athens and Atlanta offices that have gotten this. Neil will be back in Ohio to go over this in person with his practices in the next couple of weeks. I think we've got 3 weeks from now he'll be there. But we will be sure to send you the dropped HCC list before that. Watch your inbox this week for digital lists of dropped codes. We really do want to pick up as many of these before the end of the year as we can. You know, everything that we do right now affects our benchmark for next year. So we're looking ahead into next year. But the timeline is now. We're rolling this out now. And if you are chomping at the bit and ready to get this going in your clinic, give a call to your consultant right now. Let them know that, hey, I want all this stuff today. I want it tomorrow. Let's meet this week. But we are currently in the process of rolling this out. All right, Neil, I've unmuted you. Do you have any final comments before we wrap up today?
No, I think you captured everything that we needed to, and just like Amy mentioned, to all the Ohio docs on the webinar, I'll be there in the next couple weeks. But in between that time, I'll be sending out different lists and action items that you can get started on, and then I can walk you through anything else that's needed at that time.
All right, well, we thank you all so much for joining us today. Again, this is recorded, so we will send this out along with the bazooka again, and keep an eye on your inbox for more resources. Let's get to work and see what we can do before the end of the year. Thank you all so much.